having this discussion for these particular populations in regards to the COVID-19 pandemic. And Dr. Veizis, you may begin.
Yeah, first of all, good afternoon to everybody. Thank you very much for the invitation. It's a pleasure and honor. And I really appreciate the work and the efforts that EMSA and the medical students are doing in order, first of all, not only to identify what are the problems, but at the same time to see how they can contribute through being a part of a wider movement, including FMSA and other medical students, and joining forces with other organizations. So my name is Apostolos Veizis. I'm a medical doctor. I'm a general practitioner, and currently I work for MSF as the director of the Medical Operations Support Unit here in Greece. Just to mention a few things, the MSF, it's an international organization that was founded in 1971, is present at the moment and providing medical and humanitarian assistance in more than 70 countries. And currently in Greece, we're working with asylum seekers and refugees in the Greek islands, but also in Athens, trying to support them for the medical and humanitarian issues. And of course, COVID is a topic that it's added into their issues and needs. Now, why we're having this discussion for refugees in regard to COVID-19 pandemic? We're having this discussion because normally as a society, we take discussions for something when part of our population or groups of people are being not seen as part of the same society. So unfortunately, as we are talking, and I know that in EMSA you feel always as European truly, I have to tell you that European truly, it does not be and is not reflected on how Europe is taking care of refugees and asylum seekers. So the reason why we have to discuss today is because in addition to what is the situation today for thousands of children, women, and men, just to give you an example for people living in the Greek islands, there are about more than 38,000 people who are living in a place for 6,095 people. And the exposure of these people to COVID-19, that would be, and that means a disaster. So they were not part of any plan. They are not yet part of any plan. In addition to not providing services, the authorities are putting more and more restrictions that makes the situation for these people more difficult because it increases the fear, the pressure, and the violence, and it exposes these people to more risks. And risks are related, first of all, with the three questions we've been raising around in Europe. Keep a distance. The distance, if the place is made for 6,000, you have 38,000, it's very difficult. When you're asking people to wash their hands, there are places where there is one water point for 1,300 people. There is a tent of less than 3 square meters when you have 6 to 7 people, so keep a distance that does not work. And when you ask people if they have symptoms to call the doctor, in many places there is one doctor for 7,000 people, or there are 3 doctors for 20,000 people. So in a way, it's the perfect environment where COVID-19, the most democratic virus, who so far does not know any borders, any identity, is being spread. So why we're having the discussion, because we have to talk about a population that is being forgotten, a population that is being treated as numbers so far. And we need to remember and to remind and to tell both the European Union, but also to everybody in Europe and around the world, that beyond these numbers are human beings. So that's why we have to talk about human beings and COVID-19 pandemic. Thank you very much.
And Mr. Adriatik, you may proceed.
Thank you very much, Anna. Thank you very much to the organization that is hosting the discussion. I think it's quite noble, and I feel very proud that the medical students themselves are having such an initiative to speak about the vulnerable population and access to the healthcare, and dedicating one specific panel on discussing on the vulnerable groups. My name is Adriatik Hasantari. I'm the vice chair of the ERGO Network. ERGO Network, long name is European Roma Grassroots Organization Network, has been established in 2008 by a small group of organizations that shared the views that everyday realities of the Roma community were hardly taken into account in policy development and implementation. ERGO Network today, as we speak, has 30 member organizations across Europe, including Unequal fits, enlargement and neighborhood countries. And it's founded on the philosophy of active citizenship, shared responsibility, and grassroots empowerment. ERGO Network's members aim to convince policymakers that positive change for Roma is possible when anti-Gypsyism, specific racism towards Roma and Sinti and travelers and other groups that are perceived as Gypsy in the public imagination as the root causes of the social inclusion, and therefore tackling the inequalities that Roma are suffering across Europe. Now, why we're having this discussion for Roma population in regard to COVID-19 pandemic? Simply, as Dr. Veizis already mentioned, that the most vulnerable groups are affected disproportionately with other groups. It's not that, as it was mentioned, this virus is very democratic and inclusive, so it affects everybody. But through ERGO Europe, we have seen that most of the government had failed to design or implement specific measures to address the vulnerability of Roma during the COVID-19 pandemic. Marginalized Roma are among the most affected and impacted by COVID-19, mainly due to their devastating living condition and exclusion, along with widespread anti-Gypsyism. Most Roma living in poverty find it very hard to protect themselves from getting the virus or spreading it further, if infected, by lack of access to the water and sanitation necessary to washing their hands frequently and sanitizing their living space. This is even harder for the Roma who are homeless, and they're living in the segregated places or illegal camps or whatever it is that does not allow to have a dignified life. Despite the massive lack of data on the situation of Roma during this pandemic, reports from our members share that disproportionately negative impact of both the pandemic and the security measures associated with Roma communities across member states, enlargement and neighborhood countries, aggravated by long-term discrimination and anti-Gypsyism. Having said this, is that most of the Roma are working on the so-called gray economy or in informal sector or self-employed. So when the countries took measures to isolate or to close the borders, these people, these citizens, were unprepared to get along with their life. So if for some of the majority population, this was just changing from the routine, and while cooking the best meal at home and sharing the best time with the family members, for the most vulnerable one, this has been an unbearable situation. Thank you.
Thank you. Also, a small clarification for the speakers. You may turn on your cameras when you're speaking so that everyone can see you, if that's all right for you too. Okay. Yeah, it might be better for the interaction. Thank you. And now we can go with Mr. Lachwitz.
Well, thank you very much for inviting the European Disability Forum to take part in this panel discussion. I'm Klaus Lachwitz from Germany, executive member of the European Disability Forum and chair of the Human Rights Committee. EDF is an umbrella organization representing and defending the rights of more than 100 million persons with disabilities in Europe. We are led by persons with disabilities and their family members and advocate for the rights of all persons with disabilities from various disability groups. We represent persons who are deaf, hard of hearing, blind, visually impaired, or even deafblind. And we fight for the rights of persons with physical, psychosocial, and intellectual disabilities, including people with multiple disabilities and high support needs. We also adopt an intersectional approach in our work by, for instance, examining issues faced by persons with disabilities from other marginalized groups, such as women and girls with disabilities, refugees with disabilities, older people, etc., etc. Well, why are we having this discussion for persons with disabilities? Since the beginning of COVID-19, people with disabilities are disproportionately affected by the pandemic. They face a lack of support in their daily lives. They are more at risk of becoming infected by the virus. They are more at risk of not being treated sufficiently and in time, and they are more at risk that their human rights are neglected or even violated. It is therefore necessary to discuss human rights matters which are of utmost importance for persons with disabilities, such as access to health, the right to equality and non-discrimination, the right to life, and other human rights which are closely linked to the right to health. We are aware that the pandemic is an immense and never before seen challenge, creating situations for medical staff, including you, medical students, and future doctors, which require the implementation of unprecedented measures and decisions. However, such measures must be guided by the respect and application of fundamental human rights, and persons with disabilities must be involved in the decision-making processes. Otherwise, the health and even the lives of persons with disabilities are endangered, not only because of the virus itself, but because of discrimination and negligence. Thank you.
Thank you. And now there's Ciánan. Please, you may proceed.
Can you hear me all right? Yes. Okay, great. Hi, my name is Ciánan Russell. My pronouns are they, them. I am a senior policy officer at ILGA Europe. ILGA Europe, our long name, is the European region of the International Lesbian, Gay, Bisexual, Trans, and Intersex Association. Our region represents more than 600 organizations from 54 countries. We take the sort of very, very broad definition of Europe, so from Iceland to Uzbekistan and Russia. And down to Turkey. The organization was founded in 1996, and we do essentially three things. We work on advocating for human rights and equality at the European level, be that at the European Union or in the Council of Europe spaces. We work on strategic litigation at the European courts, both the European Court of Justice and the European Court of Human Rights in the Council of Europe space. And we work on movement building and strengthening the LGBTI movement and organizations in the region. Specifically, why are we talking about LGBTI issues and COVID today? Firstly, as the other speakers have already pointed out, this is a marginalized community of people, and in the context of crisis, marginalizations exacerbate. That's not to mention that in this particular moment, we're seeing really dramatic rollbacks of protections or even infringements on fundamental rights for different members of the LGBTI community. Very poignant example being what's happening in Hungary right now with the attempt to make legal gender recognition legally impossible in sort of the context of this crisis. And part of the reason that happens is because LGBTI people are actively scapegoated by politicians, particularly as we see a rise in populism and far-right voices in politics in Europe. And in the context of the pandemic, there have been examples across the continent of religious and political leaders actively blaming LGBTI people for the rise of the pandemic in the first place. And there is a sort of massive rolling campaign in Turkey right now where it started with a religious leader saying LGBTI people started this, and that's been picked up now by several political leaders and has created quite a complicated circumstance. And if I'm completely frank, LGBTI people are really desperate right now. our community already had massive limitations in access to a variety of human rights, and I'll talk a bit about that later when I respond to a different question. But as there are economic and social contractions in all around the world, those are hitting the LGBTI community particularly hard. You may have heard about a week and a half or 2 weeks ago, a trans woman in Georgia self-immolated, lit herself on fire in front of the parliament to try to draw attention to the fact that the Georgian response to the pandemic was not accessible to LGBTI people, and particularly trans people in Georgia. And that is a particularly gruesome example, but she's responding to something that's happening all over the region, where our community, already underserved, already underemployed, already under resourced in terms of access to dependable housing, are now finding themselves in an extraordinary crisis at the same time as governments in the region are saying that our community don't matter and don't deserve access to fundamental human rights. So there's this sort of perfect storm happening for the community. So that's why I'd say we're having this conversation now.
Thank you, Ciánan. As we can see and probably already knew to some extent, refugees, rural populations, people with disabilities, and LGBTQI+ really face these extra difficulties during this pandemic. And it's not like they are the only ones who are facing these situations, but the pandemic came to exacerbate these already difficult conditions. So moving on again with Ciánan, what is the situation with access to healthcare of this population? Are there any unique needs that are not met?
There are three specific things I want to talk about in answering this question. The first of them is the ongoing dialogue around what kinds of care are vital. And who's making those decisions and with what politics, right? So there are some very specific examples about that where problems are arising when it comes to LGBTI people's access to care. The first of them is a bit more general, but that's all sexual and reproductive health and rights care has been curtailed. That includes access to abortion and contraceptive services, as well as access to in vitro fertilization and other services that LGBTI people also participate in. So that problem is a much bigger problem than just our community, but is certainly impacting us. Things that are a bit more specific, as we know in Europe, a large portion of the people who are HIV positive or are part of a need in response to the HIV AIDS epidemic are members of the LGBTI community, are trans men, are gay men, trans women, and some trans men who have sex with men. And continuing access to HIV care has been limited by the pandemic. But it's also been an opportunity because many countries were unable, for example, to provide self-testing for HIV, and the pandemic has allowed or pushed governments to change the law or change the policy so that self-testing could be done. So workarounds have been happening, but there's definitely been a concern about continuation and access to care. And there's also an ongoing concern about shortages in medicines that might impact HIV care in the long term, particularly as we see sort of the rolling implications of shutdowns in different places and where different of the starting materials of medications come from. So this is a long-term problem. Additionally, trans and intersex people experience some very specific problems that are unique. For both trans and intersex people, ongoing access to either transition-related care or care related to their variation in sex characteristics has been generally deemed non-vital by governments. And what that means is that appointments have been canceled, deferred, or delayed in ways that, particularly for trans people, have a very long-lasting psychological impact. Trans people's surgeries have been canceled or postponed, and often for trans people, the process of waiting for that surgery in itself, the date is the date that they're trying to survive to. So when that is canceled or postponed, it can have a really significant mental health impact. There's also a problem, though, with continuing care, and that's access to ongoing hormone treatments and to follow-up care for surgeries that took place before the pandemic started. And many people in Europe have expressed that they were unable to access ongoing hormone care for a period of time. I'm not sure if that's still going on now that things start to open up, but that meant that people were self-medicating or skipping hormones. And if someone has had a sterilization surgery that removed their gonads, then that could create really long-lasting health impacts. The second point to make here is about discrimination in health settings. You may have seen today, that the Fundamental Rights Agency's very large survey of LGBTI people was released today, and one of the things that's in there indicates that 16% of LGBTI people generally have experienced discrimination in a healthcare setting, and that more than doubles when speaking specifically about trans and intersex people. It's 34% of trans people and 35% of intersex people. And additionally, trans and intersex people, when they have been experienced physical or sexual violence, notably 1% of that, the most recent experience, was in a healthcare setting. So there is physical and sexual violence against these communities taking place in healthcare in addition to discrimination. And what that means is that it causes people to delay or avoid going to get care in the first place because they frankly don't trust the system to take care of them and to meet their needs. And that obviously exacerbates the problem when people need to be accessing care quickly so that we can diagnose, test, and treat to try to contain the pandemic. And the final thing is about, and this will be extremely brief, is about when quarantine and confinement systems inside medical institutions are sex segregated. There have been incidents of discrimination and harassment in that context where people are unable to be housed in places that match with their gender identity, or they're subject to interphobic, transphobic, or homophobic discrimination or violence in those settings. So they're particularly precarious settings for LGBTI people.
Thank you. That was really insightful, Ciánan. Dr. Veizis, you can continue, please.
So, first of all, as we are discussing with medical students that some of them in a few months and some of them in a few years will be medical doctor, I'd like to remind, first of all, what is the definition of health? So health is a physical, mental health and well-being, and that's a definition how WHO defines. And so also another issue is to what we understand with access to healthcare. So we need to understand, first of all, access, it's one, accessibility is something else, acceptance is another one, and then quality of care is something different. Now, most of the European governments have been seeing the health separately from the rest of the things. And health has been seen something that is not important for the humans. So the access of the refugees into healthcare is facing a lot of barriers that are related with different laws that governments are implementing by considering and linking the access to healthcare with the legal status. So to give an example, from 2019, from July, the new Greek government decided that all the newcomers in Greece will not be having access to security number that allow access to prevention, access to treatment, and will allow them only for emergencies. So what does it mean for people that are being stuck as asylum seekers or refugees in the camps? First of all, already by living in the camps, people are facing mental health and health issues. So they're getting sick because of this environment. Secondly, the state responsibility for the refugees, it is very limited, offering medical services. And thirdly, by not allowing people to have access to healthcare, we are seeing already outbreaks of different diseases, including hepatitis A, meningitis, and measles. We see a lot of people with chronic medical conditions like diabetes, cardiovascular problems, cancer, and trauma who are not getting treatment. So in front of this situation, and especially in front of COVID, people who have chronic medical conditions, first of all, it will be more vulnerable because they don't get their treatment. Now, the understanding also of public health, because first of all, the word is being used very often now these days due to the COVID-19. Public health is something that if you don't include everybody and if you don't design programs that have to do with prevention or with treatment, access to treatment and other exercise, it's something that would not be considered anymore public health. The World Health Organization, when they distributed the report in 2018 about the health of refugees in the European countries, and that is beyond the European Union, it's in European region, they presented that most of the refugees and migrants, they are healthy, and they get sick when they are, first of all, living in not proper conditions. Secondly, when they are being not integrated into the society. So WHO is recommending and is being promoting by saying that we cannot see health of the population without refugee and migrant health. Now, in order for this issue not to remain as a slogan, there is a need for an action that divides, separates the legal and asylum process from the issue of access to healthcare. And of course, in a period of COVID, this is something that has to be even removed as a barrier in order to ensure that people are being diagnosed early, people are being isolated or people are put under quarantine. And at the same time, the treatment will be available when that is needed. On the contrary, also at the same time, European unions have been closing borders for people that are in need of protection. So if somebody is in need of protection, unfortunately, you cannot wait for the borders to be open because his life is in danger. But also what we see, in addition not providing healthcare into refugees in Europe, we see a stigmatization. So the refugees and the refugee camps are being presented as a danger for the local population. We see a stigmatization of these people as the one to carry diseases, while our medical data from our clinics in Lesbos or Chios or Samos or Athens shows that most of the refugees, they face medical issues like the general population. And of course, most of the medical problems that they have are related with the living condition. Something that is very important to mention is the issue of mental health.
If you could please wrap up. I'm sorry for interrupting.
Yeah, no, I'm fine. So in addition to health, we need to remember also that mental health is a big issue, and we have the forms from people who are trying to commit suicide or harming themselves. So yeah, health of the refugees and mental health are in danger in Europe these days. Sorry for the...
Thank you. And Mr. Adriatik, you may continue. We cannot hear you. Sorry.
Can you hear me now?
Yes. Yes. Thank you.
Okay. I think it's very difficult to speak on access to healthcare in general at this given situation. But in the case of Roma, there were already a lot of problems, what I call it, in the past, and that's the period before the COVID-19 pandemic. That was, of course, a lot of discrimination. The system was not affordable, was not accessible, and was not available due to lack of human resources. Doctors refused to go to work in the Roma communities, and so forth. So that, but then, and then we had this pandemic happening. It's like the views and the perception across all these countries which have been into quarantine is that they didn't have access to healthcare, and that's perception, because when you're asked to isolate, you would take precaution and medicine to your home, and that was not the case for many Roma across the Europe and also in enlargement and neighborhood countries, because most of the Roma were almost close to humanitarian crisis. If not, some of the families did had a humanitarian crisis, which is still ongoing. So then the luxury to think on the medicine, you will not even think for how to access the health services. And therefore, if you do you are doing something good for the country, because you are being shut down in the country, or you are being isolated because you have to protect the health system. With this, I don't want to underestimate the role of many noble doctors and nurses and health workers who were there on the front line and fighting with the virus, and then they did save many lives and did much more than that. But that has been the situation, and I don't perceive the situation will become better when this pandemic will be over. access to healthcare has been an issue across Europe, will remain an issue. And some of the clear facts we have, because we had a shutdown in all the countries. If the healthcare system would have been strong enough, we will not have such strong or classical isolation among the families. We had across Europe communities quarantined with the police and checking point, not leaving members of the community to go out, but also not helping with food and medical supplies to make sure that they will have or guarantee a life after quarantine. So with this, I cannot say that I can say that the access to healthcare at this pandemic, during the pandemic, has been a real issue, which we think it will continue as well. Thank you.
Thank you. And Mr. Lachwitz?
Well, we are extremely worried that in some countries, medical guidelines for COVID-19 pandemic are discussed or already exist, which discriminate against persons with disabilities. Triage seems to be practiced at some points based on such guidelines. Due to consistent underfunding of healthcare systems, for instance, medical personnel is overwhelmed by cases, and doctors working in COVID-19 hospitals sometimes seem to have no other choice but to prioritize. But one thing is for sure, such guidelines are not in line with international human rights law and prohibited if they exclude persons from receiving medical care on the basis of their disability. But fortunately, there are already some ethical guidelines available which could serve as good examples to avoid discrimination and negligence. For instance, the Bioethics Committee of the San Marino Republic published guidelines in particular for COVID-19, which states the following, I quote, "The only parameter of choice is the correct application of triage, respecting every human life based on the criteria of clinical appropriateness and proportionality of the treatments. Any other selection criteria, such as age, gender, social or ethnic affiliation, disability, is ethically unacceptable, as it would implement a ranking of lives only apparently more or less worthy of being lived, constituting an unacceptable violation of human rights." End of this quotation. But I repeat, this is not the case in all countries. For instance, in my country, in Germany, the members of the House of Parliament were asked by an alliance of disabled persons organizations fighting for self-determination to discuss a law on triage and to include persons with disabilities and their representative organizations in public hearings before such a law is adopted. But this was refused by the government. Instead, the Ministry of Health took the view that it is a responsibility of medical doctors to decide on the basis of guidelines published, for instance, by VIY, an interdisciplinary alliance of experts working in the field of intensive and emergency medicine. But careful reading of this paper shows that persons with disabilities or their peers and persons of trust are not included in the decision-making processes, and that outdated clinical frailty scales are used to enable medical staff to prioritize persons infected by COVID-19 who need treatment. Well, some members of EDF report that not all doctors are aware of the rights of persons with disabilities. Some of them see and qualify them as persons who are sick, weak, or burdensome. This is a very sad reality that really affects persons with disabilities. A medical doctor told Severine, a woman with disability from Belgium, that she would be deprioritized if she had coronavirus. In Alsace, staff of a residential institution for persons with disabilities informed the newsletter Le Monde that quite often they watch doctors and hospital workers breaking down when they need to treat persons with disabilities. I quote, "They sometimes even send them back to us without touching them. They are not used to deal with them." Thank you.
Thank you, Mr. Lachwitz. So access to healthcare seems as a political choice in some cases, and even though the right to health shall be respected and ensured by the governments, we see that there are many who cannot enjoy it at its full potential. And in this time of COVID-19 pandemic, disadvantaged communities and vulnerable groups are particularly exposed to the health effects of unequal access to healthcare, or that could even be inadequate housing, living and working conditions, which result in even poor health. So what other issues are this population facing that may bring their well-being in jeopardy? Which of their human rights are violated to you? Mr. Lachwitz, the microphone back to you.
Well, one sensitive issue is the forced placement and forced treatment of persons with disabilities. Because many governments in the EU still allow it, too many people with disabilities, in particular people with psychosocial or intellectual disabilities, autistic persons, people with dementia, etc., are very often subject to placement and treatment without their personal consent. The consent can be given by a guardian, a parent, another family member, or an institution. But this is not in line with human rights, as Article 12 of the UN Convention on the Rights of Persons with Disabilities prescribes that every person, irrespective of the kind and degree of disability, enjoys legal capacity. This has to be carefully considered if the person formally expresses his or her opposition. If this opposing gesture or attitude is ignored, the dignity of the person is violated, and that is something what we very strongly condemn. For all medical procedures, treatments or placements, it is necessary to obtain the free and informed consent of the patient. If this is not possible, medical doctors should apply the best interpretation of will and preferences. This is very important, as forced treatment often leads to trauma and mistrust in the medical system. Another issue that is amplified with the pandemic is the lack of support for persons with disabilities to live independently and the neglect of people living in institutions. In some EU countries, people with intellectual disabilities, for instance, still live in huge institutions, which is against Article 19 of the Convention on the Rights of Persons with Disabilities, which states that all persons with disabilities have the right to choose their place of residence, and that they are not obliged to live in a particular living arrangement. We were confronted with a very high level of deaths in institutions. 2 weeks ago, we were informed about horrific situations in Romania. 242 residents living in an institution named Zasca Mica were infected by COVID-19. It is a nightmare, as none of them was transferred to a hospital, while the staff working in the institutions was. This is a classical example of discrimination. I also want to highlight issues of violence and abuses, often impacting people living in institutions, but also other people with disabilities, in particular women and girls. Doctors can have an important role in identifying and reporting violence. Domestic and gender-based violence obviously has risen during the pandemic, impacting in particular women and girls with disabilities, who constitute 60% of the population of persons with disabilities in the EU. It is really difficult or even often impossible for them to report violence as services do not work or are inaccessible. Medical professionals can not only help to heal, but save the lives of victims of violence.
Thank you, Lachwitz. So what is the situation with LGBTQI plus Ciánan? You want to continue?
Sure, I had myself as third in this round, but I'll go. Yeah, so I think it's actually a really good segue from what Mr. Lachwitz was saying about forced treatment first. Trans and intersex people are also subject to forced or unconsented treatment, though it's in radically different ways. But these things are not in any way helped by the pandemic, and may in fact be exacerbated. For intersex people, the FRA survey that I mentioned earlier that came out today indicated that 62% of respondents who had surgery underwent that without their informed consent. And 49% of intersex people who had other types of interventions like hormone treatments underwent that without their informed consent. And that creates a context of massive trauma, as Mr. Lachwitz was saying, as well as mistrust in the system. So there's the additional barrier in the context of COVID-19 of people just being unwilling to go to the doctor, or of their trusted medical professional being far away, and quarantines and lockdowns making it difficult for someone to go to someone that they do not believe will violate their right to freedom from torture. So that's a complication. Additionally, lesbian, gay, and bisexual people are facing difficulties with family protections in this context. There are already significant barriers to family reunification, acknowledgement of relationships, as well as of birth certificates of children in rainbow families, and that's only exacerbated when there are barriers to freedom of movement on the continent. Sort of connecting in to the other commentary here as well. Many asylum seekers who are LGBTI do so not via the pathways in Southern Europe, but because of very individual specific fear for safety in their home countries. And we are aware of people who had plans and even tickets and visas to flee those violent circumstances, who are now forced to remain locked down in a country that has become no more peaceful or safe for them, as societal sort of hysteria has built up. So that certainly also comprises a problem. Additionally, there are really significant exposure to discrimination that LGBTI people face. The FRA survey indicates that 17% of LGBTI people generally have experienced homelessness in their lifetimes, and that jumps to 25% of trans people and 29% of intersex people. So one marginalized population that's not present today, but that is really relevant to conversations about medical care in the context of COVID is those who are experiencing homelessness, and that there's an overrepresentation of LGBTI people among that population. So dealing with homelessness is not just about creating more houses, but also about discussions of the context in which people live, and what creates and causes homelessness. Also, with the economic contraction, there's an overrepresentation of unemployment and exposure to discrimination in the employment setting for LGBTI people that will only exacerbate the economic consequences for this population. And so the ability to access one's right to non-discrimination is severely hampered for LGBTI people, both in these times and in quote unquote normal times, or in the before times, if we sort of think of this as a start of a new era for our planet. And the final thing is about privacy. There have always been rather significant violations of particularly trans people's right to private and family life in the climate of legal gender recognition mechanisms that bring a third party into deciding whether or not I can change my documents, which in itself is a violation. But as there is an increased amount of policing on the streets, those privacy issues are only exaggerated. There are, in Belgium, where I live, have been examples of same-sex couples walking on the street. 10 seconds and I will be done.
Yep. Okay.
Same-sex couple walking on the street having their residents together challenged by police. So there's this pervasive discrimination and stigma that impacts all of these. Thanks.
Thank you, too. Even though these are really horrible conditions, I believe there are quite many similarities in the case of refugees, as Dr. Apostolos mentioned also earlier. Could you continue, please?
Yes, unfortunately, I have to continue with a bad picture. So if we come to talk about well-being, I think as medical students, time to time, you read the Maslow pyramid about what are the needs of people. So if we stay on the basic needs of a person, that means a shelter, that means food, water. Today, in many European settings, we see that even the basic needs are not being met. Also, I have to remember you that following the UNHCR and SPHERE project minimum standards, in refugee camps, you need to have 1 toilet for 20 people, 1 shower for 50 people, 1 soap per month, and you need to have 15 liters to 20 liters of water for individuals. That means water for drinking, cooking, and also taking a shower. These minimum criteria are not being met today in Europe, and this is something that is very sad. And this is not coming because of the lack of resources or lack of financial support. It's coming, first of all, of a policy of no political will, and secondly, this is being done on purpose in order to minimize the number of arrivals, because the policy says that if you keep them in bad living conditions, less people are going to come. Now, these living conditions have an impact, first of all, on their physical health. So you see a lot of upper respiratory tract infection, whether people have to sleep outside or being cold. You have a lot of skin diseases. People are having a lot of scabies issues. You have a lot of cases with diarrhea. So in a way, the well-being of people itself, regarding the physical health, it's under danger. And then, of course, this environment, you have overcrowding. People have to queue just for food. They have to queue 9 hours a day, 3 hours per meal. They have to live in tents with other people they never met in their life. And also they have to live environment of violence, because when you have less resources, people have to fight with each other. And when, for example, inside of the family, the members of the family are not being met, they're not covering their needs, you have more and more violence that is called, not domestic violence, but I have to call it as a tent violence between the community, including the sexual violence to this population. Now, of course, when we have to talk about what are the violations of human rights, this is a sad story, because when I ask this question to many other medical students, but not only, also to my colleagues as medical doctors, they believe the violation of human rights is being done in other countries and not in Europe. And I'm saying that because all of us probably we heard about human rights, but I think it's important to remember that the declaration, it comes back in December the 10th in 1948, is translated in more than 500 languages. That means that it is the most translated book on earth, even than the Bible and Quran and other religious thing. The issue of implementation is becoming problematic. So which other human rights have been violated? Access to health definitely is violated. Article 24 about right to leisure and rest is being violated. Article 25 about the right to safe and standard of living is violated. The right to freedom of movement, Article 13, is being violated. The prohibition of torture and cruelty is being violated. And I'm saying that because today, what we see in the refugee camps, we see ill treatment and goes to the level of torture for people. And of course, Article 7, that is the violation, is being violated regarding discrimination. So we see a systematic discrimination of the people. I mean, today, for example, the COVID-19 exercise says that from the 4th of May, the local population, that means the Greek citizens, they can move out of their houses, while the refugees, they have to wait till the 21st of May. And from 7 o'clock in the evening until 7 o'clock in the morning, they cannot move out. They can move out one member of the family. So in a way, we see that there are a lot of human rights violations. Yeah, so I think it's important that to learn very well what are the human rights in order to see which of them is being violated.
Thank you so much. And Mr. Adriatik, you can have the final point on Roma population as well and their human
even
rights
though
violations.
most of the things has been, and I don't want to repeat the previous colleagues, because everything has been said, but I wanted to remind you that if you would have seen the composition of any technical group in each country, I didn't came to my knowledge that all this technical group who were designing measures to be followed during the COVID-19 pandemic had any human rights experts in it. So with this, I think you might get all the possible questions you could have already answered. Now, to answer how human rights have been, or what are other problems out there, I would underline again the living condition and poor infrastructure on the Roma communities. That had a huge impact on access to healthcare, being affordable, being accessible, and being on the other hand, as we're protecting the public health, and apparently has been designed that in order to protect the public health, you need to take some rights away. Well, most of the measurements being taken didn't satisfy themselves just having some rights away, but actually assimilating all the rights away by the global goal, noble goal they had on the public health. Now, in different countries, this has been drastically implemented, change of laws being voted during the night without consultation, without discussion, because the time has been given. So we've seen countries going to really far rights and holding the power on one man in the country, and usually that has been the premier in that given country. And that, of course, it had impacted overall population, and mostly it had impacted the most vulnerable groups, including Roma. Anti-Gypsyism has been widespread, and we have seen severe anti-Gypsyism. We have seen a man was killed in Spain because a Roma man was killed in Spain. A Roma woman did not receive her services at the hospital because she didn't have a proper documentation, even though the pandemic itself would explain you that during the pandemic, you don't have emergency crisis because the doctors will not be there to respond to you, because again, for protecting the public health. So there have been a lot of policies around, and in the beginning, also we were questioning ourselves how we need to make sure that we are engaged in such a discussion, not so much taking what I would say an easy step into advocacy to not agree with most of the measures that were proposed, but rather than to say, okay, how we can help the government across the region or across Europe, how we can make a better use of such measures. We have been, ERGO Network,
Yeah, please, if you could wrap up. I'm sorry.
Yeah, ERGO Network and its secretariat, which is some fantastic people there in Brussels, but not only, they're present everywhere through this fantastic online communication. They've been raised their voice into most high-level mediums to be understood what are the situation and needs to be taken on board. On the other hand, I hope, as it's been said, that after the measurements will be released, we will go back not so much to the normality of above the social distancing, but rather than on having the rights back. And then we will be able to assess whether we will take those rights back, because some of the laws being implemented across Europe or being voted across Europe and enlargement countries and neighborhood countries are really worrisome. Thank you.
Thank you too. These were really horrible situations to imagine even. And we know that these disparities in human rights pre-existed, but COVID-19 came to not make these situations easier. And even though most of us are out of the scene, either because classes were moved online or our clinical rotations were postponed, we still have the capacity to make some change and contribute to society. So moving to our last question, and if you could please be as brief as possible, because we were trying to reach 1 hour of the main panel discussion and then move on with more questions. What do you think from your population's point of view should be the role of medical students in their communities as future healthcare providers, as well as potential human rights advocates? Mr. Adriatik, yeah, the mic to you.
I think it's fantastic what you are doing already. I mean, it's very rare to see medical students getting information on most vulnerable groups, because most of us at that time or also now are focusing on their studies. So maybe this pandemic is also bringing some awareness on the future doctors on how you need to engage with the people, and how just curing someone or helping someone health or treating someone as a client or as a patient will not really help the noble goal of having a good public health. What I think medical students should do, it's should raise awareness, should increase their education on different various population groups to understand who are these groups. And there is a lot to do in promotion. In promotion and in health promotion, it's a lot when medical students can be engaged into different communities or in different centers to make sure that citizens do receive the right information. Thank you.
Thank you. Perfect. Mr. Lachwitz, what about from the people with disabilities view?
Yes, medical students have a tremendous role to play to ensure that everyone has access to healthcare. They can also help and fight to end stigma against persons with disabilities and special groups which are disadvantaged. To treat each patient with respect, ensuring their rights and which are granted, and respecting their wishes is fundamental. People with disabilities refuse to be seen as objects of care or charity only. They are really fed up and get furious to be seen as disposable, or to be told indirectly that their life is not worth living. In the COVID pandemic, we see that the marginalized groups are the ones most affected. This is also true for the marginalized groups among medical staff and medical students. You all have a role to fight against discrimination in the pandemic and in other challenging situations which will cross our ways. I would thus call you to consider each patient in a holistic way and paying attention to various facets of their identities, may it be disability, gender, sexual orientation, etc., etc., etc. Well, finally, I want to thank you again for your invitation and for organizing this really interesting discussion. Thank you.
Thank you so much too. And Ciánan?
I have some very practical things, because I agree with everything everybody else has said, but just to sort of hit the nail onto practical things. One of them is you can ask for specific training in your curriculum. And the more students that ask your faculty, the more likely they are to pick up and cover a topic. So ask for a class, ask for a session on specific marginalized groups, so that you can have a bit more awareness about those things. And part of it is about normalizing. So when it comes to LGBTI people, for example, as I did when I introduced myself at the start of the webinar, I said, my name is blah, my pronouns are they, them, right? When I said that, what I did was invite all of you to think about the possibility that you might also be able to tell me your pronouns, or tell me something else that might be about your sexual orientation, gender identity, gender expression, or sex characteristics. You set the tone. So consider the kinds of things that you do and the ways that you talk about who you are, and ask questions about your patients as setting the tone and creating either an open and accessible space for LGBTI clients and patients, or a closed or scary one for them. That also means incorporating gender neutral language about sex partners, about sexual activity, and about body parts, and asking people how they refer to their body parts rather than saying female genitals, male genitals. You can ask, what are the right words that you use so that we can talk on your level? And that it comes back to what Mr. Lachwitz was saying about patient-centered care. And finally, two very, very practical things. One of them is ask your patients how they want to be referred to and write it down on the chart so that they don't have to answer that question every single time. You can be an active advocate for patients to make sure that they're being referred to in a way that allows them to be honest and open with you and not already feel stigmatized or discriminated against in the context. And the other thing you can do is find out if there is a gender-neutral bathroom in your clinic or in your hospital and know where it is. And if there's not, talk to your administration about why there isn't and whether it can be possible to make one. So very, very practical sort of ways that you can make an inclusive space are the things that I would suggest. But at the top of that list is ask your professors if there is a class, and if there isn't, why there isn't, and get it on the curriculum. That's probably the most impactful thing you could possibly do.
Thank you. Perfect. And Dr. Veizis?
Yeah, I know, and I had the chance to be at the EMSA General Assembly here in Athens, so I know that you are working on asking for a change on the curriculum. So I'm looking forward for the becoming medical students that this curriculum is being changed. So that what is an important thing is that as medical students or as even the future doctors, you don't have to go in other countries to see the violation of human rights. Already we are receiving people as refugees where their human rights have been violated in their countries, but these human rights are continuing to being violated also in Europe. I think what is an important thing as medical students at the moment, you need to ask also from your professors, what does it mean to engage in the so-called patient-centered care? A term that today is being thrown around a lot and is being discussed a lot. So I think the role of as a medical student while we're learning how to respond to the medical needs of the person is also to understand that our role as medical students and doctors is beyond and further out of the provision of the medical care. So as doctors, we need to advocate for our patient and stand up for the patient's basic human rights violation. Now, when it comes to the refugees, as health professionals you are, it's important to assess the complex continuity challenges for the well-being of children, women, and men who are refugees, not only with the aim to support them and provide medical care, but at the same time, I think it's important to act as advocates for refugee rights, for the anti-discriminatory policies and social justice. And I think today, if you are teaching yourself to be a very good doctor with an approach that you don't see yourself as a clinician only, but you see the patient outside of that, and you advocate for these rights of these people, I can tell you that this is the best thing you can do. And don't expect yourself to be in a refugee camp distributing something, and you can do it later on as a medical doctor. So I think at the moment, what I would suggest as medical students, keep doing what are you doing at the moment, because it's important that you inform yourself about the situations about. Secondly, try to access proper reporting system that comes from different organizations, including MSF reports as a medical organization. So you will be able to use these tools and your power being millions of students in Europe and internationally as medical students in order to raise the voice. And I'd be sure that your family members, your neighborhood, and everybody will listen to your voice, because first of all, you are important people, you are medical, and I think at the same time, you are talking as a medical doctor and you're not talking as politician. Unfortunately, even when we implement medicine, we need to be politician in order to protect the violation of human rights, and the basic one, that is access to healthcare. Thank you.
Thank you all so much. These are really valuable tips for us that we should really consider in implementing at some point. So now I'd like to invite all our participants, if they have any questions, they can write it in the chat, and we'll try to have quick responses to questions. We already have some, so I think we could begin with these. In case some people come up with more questions, we can proceed with them. So there's a question asking, can we consider the COVID-19 pandemic as a wake-up call for all the human rights violations happening around the world? And I'd like to invite any of the speakers that feels like answering to begin, and maybe we can go in rounds, or so that we won't take up much time. Who would like to begin with this one? Yeah, Ciánan, please.
I think we can consider it to be a wake-up call, but the question is really, are we going to heed that call or not? There's a great deal of discourse happening right now about the limitations in the response, about the particular barriers to the response reaching all marginalized communities. But unfortunately, in Europe, the conversation that's happening at the political level is largely economic and not about protection of human rights. And so to be able to see this become a discussion that is a wake-up call about protection of human rights and marginalized communities, that requires all of us to be asking our elected representatives, great that you're doing this economic package, but what are we going to do about this? And more active political engagement from us, because as we can see quite clearly from the political responses so far, it is not human rights based, the discourse that's happening, and so we need to push it in that direction. I think it is a wake-up call for a lot of individuals, but whether that turns into politics or not depends on us.
If
Okay, perfect.
I may add one thing on that. I think today the COVID-19 we can consider as an opportunity due to the fact that it's affecting everybody, because we had many pandemics going on in the previous years, but this one it's affecting everybody, and also it's exposing the problematic, how the system today, not only in less developed countries but also in developed countries, have been not able to respond to that. So I think we need to change the mindset, the way how we look at things, and how we are preparing the tools. And if we wanted to be very clearly on the medical side, the tools that we're having available at the moment, or the way how research and development has been put in place, does not allow that easy to have vaccines, treatment, first of all, quickly available, but at the same time accessible and for free for everybody. So I think regarding that issue, I don't expect that all this COVID-19 will change many situations, but at least on certain areas, yes, can be an opportunity, I think, and it is possible.
Okay, thank you so much. If there is not something that really must be said by any of the other speakers, I'd like us to proceed to the next question that I think it would be nice to be answered by all of you. Do you know which countries have the most effective precautions and arrangements for vulnerable people, such as elderly and people with chronic disease, as in the populations you were referring to? Okay, maybe I should repeat the question. Do you know which countries have the most effective precautions and arrangements for the vulnerable people? Mr. Lachwitz, would you like to?
Well, I think that at the beginning, for instance, in my country, nobody talked about the problems of persons with disabilities. They started to talk about the problems of elderly people because the average age of people dying was about 80 years old. And then they started to inform people about all the problems and issues. But for instance, sign language was not used. Easy language for persons with intellectual disability was not used. So these people were not well informed. And I think that's one of the main steps, that you receive equal information and available information for everybody. Things have changed slightly, step by step, because in many countries, the disability movement is quite strong. So we have sign language interpretation now in all our television sets. But nevertheless, I would say people living in big institutions, people with high needs living at home and only well looked after by family members, they are still disadvantaged. So
Yeah.
we still have to insist that all the more marginalized groups are really discovered and properly informed, and then of course treated. And that means if vaccines are produced, medicine is produced, this should be available for all people and not for only for the rich people. Thank you.
Okay, thank you.
If I am allowed only a few seconds, I think there's been quite a big attention to COVID-19. I think we need to remind ourselves that millions of people, they are not getting access to the basic treatment. And today, in parallel with COVID, there are thousands, of patients dying daily because of other outbreaks. For example, to give you an example of Congo today, they have to respond to the needs of Ebola, needs of measles, cholera, malaria, and COVID. So in a way, COVID-19 brings once more in front of all of us the inequalities and the difficulties that all our human beings, colleagues around the world are facing. So today it is a matter of how health is being looked about. Health is being looked as a luxury. Health is being looked as a tool for people only when the money is available. So I think in order is not to quantify what is the situation, I think we need to look more at quality. And quality means we need to improve access of people to healthcare. And by improving access to healthcare, that probably these inequalities regarding health at least will go away.
Okay. Thank you.
I have a very comment on this, if I may.
Hello.
Yeah.
Okay.
Please, Adriatik,
yeah.
go ahead.
Can
Please
I?
go. Yeah, please go, Adriatik.
Because I mean, the first question I didn't hear it. I was up and down in the meeting, trying to access it. But I mean, I think it's very important. We should draw some lessons learned from this pandemic. I think it's very difficult to judge who was prepared and which of the countries did give the best help to the most vulnerable groups. To my knowledge, no one. Did they try at the beginning? Did they? Because all these countries and all the health system and all were so much unprepared and so not knowledgeable about so many unknown what the virus could do. And also to some most extent, most of them were also a lot of taking care about not losing economy and a lot of other important things in life. It was an unprecedented situation. No one has the knowledge on. So now there is now I hope we don't have a second wave, really, and I pray for not having a second wave. But I hope the knowledge being created so far would have to be used. And I hope in the second wave, we don't have to be locked down in all the countries. I hope that the first lockdown, the first isolation did help the health system across the world to get prepared. Because it has been mentioned, there are much more aggressive virus around the world other than COVID-19. So therefore, there was not such knowledge. I hope this knowledge now, and we will draw some lessons learned, not only for the vulnerable groups, which we're discussing here, but also across the world, and then that we are prepared for the future.
Exactly. Thank you. And Ciánan, some few words so that we can go with a few more questions.
Yeah, the comment I wanted to make is that institutions and governments are not responding well to across the board in terms of LGBTI people, but strong civil society is. The vast majority of NGOs that are part of our organization have redirected their efforts to focus on crisis management and responding to the crisis. And so I think the thing that I would say is countries that have strong civil society already and are continuing to support that civil society are in a better place when they fail at an institutional level to protect marginalized communities, that the civil society is ready to pick that up. That's a stopgap. That's not a solution, but those are at moment the best practices.
Thank you. Thank you for mentioning. Okay, so we have 2 questions here in the chat box. There's a question I'm not quite sure if you can answer, but we can give it a go. Asians and people of color in Europe are facing increasing discrimination in line with xenophobia and racism related to the pandemic, and access to medical care is brazenly denied. What can we do to tackle that? I believe none of you is that into that knowledgeable, but if you want to go, yeah, please.
Yes, and I can offer something on that. I think the stigmatization, it is something that is being done for years, be that on people, be that on the countries, or be that on groups of people. So I think what needs to be done is that is part of the role of the society, including the medical students, the doctors, and the rest of the NGOs, in order to remind people that diseases, they do not know borders. Diseases are being transmitted for everybody. Now, the question is that as medical students, you are very nice and you are very active and take part of it. And I think you need to keep that power and that decision also later on. Because I think you get fatigued, you be part of a society and you focus on your patient work, and this is being sometimes is slowing down. So I think the only thing, the role that needs to be taken at the moment is to come from the medical actors. So the doctors, nurses, midwives, they need to talk about it. I think now the doctors, nurses, midwives are being seen as heroes. Those heroes, it's important they raise their voice and say, this is, they don't know borders, we need to treat them, and we are prone to them, all of us, so we need to protect each other. And we need to show solidarity, and solidarity was not, is not, and never will be a crime.
Thank you. All right, so the next question I think should go to Mr. Lachwitz. The deaf hard of hearing are having a difficult time due to the utilization of masks and or limited use of translators in sign for vital news. Additionally, auto-generated closed captions are not always high quality, so telehealth options may be problematic as well. How can those in medical field help to further the care for this population for equitable care?
Well, I mean, deaf people and people hard of hearing have many problems everywhere. And we even find that sometimes these persons are characterized as persons who are not able to express their wills and to express their opinions, etc., etc., etc. It has changed slightly since we have sign language interpretation in television and in radios. But if you go to hospitals and if you go to other offices, etc., etc., usually sign language is not available. And hard of hearing people, they need really to repeat and to repeat and to repeat what they need, etc., etc. So the only chance we think is that there are social supports for these people, not only, let's say, in television, but in all official, in the hospitals, in the medical practices, etc., etc., etc. It costs money because you need specialists who can really work with sign interpretation. What I know from my own country is we have about 50,000 deaf people. All of them now can make use of sign interpretation. All of them are entitled to get support gratuitously. Doesn't cost anything. It's paid by the government. But hard of hearing people, and there are more than 1 million in my country, they are not properly supported. So captioning, for instance, is quite rare. And in other parts of Europe, I think it's even worse sometimes.
Thank you. And there are 2 questions for Dr. Veizis for MSF. So the first one is, what measures has MSF, along with the local authorities in Greece and possibly elsewhere, put in place to mitigate COVID risks during the migrant influx typical in the upcoming summer months?
Yep. MSF, as I said, is working in 70 countries at the moment. And currently, regarding the COVID-19, we also have been responding almost in all these countries. So interventions are being done now in Europe, responding to big, difficult situations, be it in Spain, in Italy, in France, in Belgium, responding also where there are a lot of vulnerable people. Now, when it comes to Greece, that is a place where the people you have a lot of newcomers or where there are a lot of refugee camps. We've been trying to work on the direction of setting up, let's say, facilities that are related with triage, screening, isolation, and quarantine. So in a way, that will allow, first of all, early diagnosis and case management, and also will allow no overburden in the local hospitals, because, for example, in the Lesbos hospital, we have only 5 ICU beds, and in Samos, we have 2 ICU beds for the whole island. So in a way, yes, MSF is bringing its own experience with Ebola and other infectious diseases in order to contribute to both supporting the local healthcare system, covering the morbidity and mortality of refugees, and like this contributing for the society overall.
Thank you. And the second question to you as well is, has the procedure of applying for asylum or for citizenship been frozen? Do you think if action is taken, countries could give access to healthcare to refugees during the pandemic?
Well, starting with the second question of that question is that today, just taking an example of Greece or many other countries, but taking an example of Greece, there is an existing law from April 2016 that allow access to healthcare for everybody. But then there are decisions being taken that people are being excluded. I think Europe and the rest of the countries, they have the possibility to allow access to people to healthcare. And I think in order to change that part, we cannot just count on the willingness of the government, because I think there is also responsibility from us as medical staff to talk about it, to talk on behalf of our patient and not and their access being stopped. So if today, for example, the medical community, like done in many other European countries, like in Italy or in Spain, saying that we are not spies to give our patient without documents, or we will offer to people what the oath of Hippocrates says. And if the doctors will raise their voice, I'm sure that things will be changing. And secondly, what is an important thing is we need to remind our governments that no access to healthcare is also more costly for the healthcare system itself, because the people will be becoming an emergency and or a chronic situation that will cost the system even more. Now, on the first point that was raised, yes, currently the asylum application are frozen due to COVID until probably late May. So COVID at the moment is being used as an excuse and is used as a barrier. So this can change away, but again, even for asylum seekers today, unfortunately, their access to healthcare is being linked with their own status.
Thank you so much. And there's another question. I believe it could be for everyone. The current state of vulnerability imposes us to include the preparations required into the environment through schooling and social gatherings to be equipped for the shortcomings in the future. Do you think this shall be a work in progress? If yes, then up to what extent? Basically, that's a general one, but asking your opinion, if you want to.
Can I?
Yeah, please go.
Yes, I think a bigger crisis than the crisis we had during the pandemic, it's the post-pandemic crisis. And therefore, it is really important for the politicians and the government to only with long-term investments in infrastructure and improving the living condition of the most vulnerable groups, they would prepare for the shortcomings, as the question is saying. If the question is also having in mind this online education, my personal opinion is that online education with the primary school mainly, it's a fiasco across all countries. You would not be able to teach new concepts to children. It's impossible for children, whatever they are, to learn new concepts and then later those apply them individually if you don't have very good house, if you don't have very educated parents that would stay with you closely. And imagine all those poor families and those groups which don't have, which are, the parents are illiterate, they don't have access to electricity, they don't have access to internet, they're on humanitarian crisis. So they're the thinking or getting getting angry because your child is not educating enough, you are getting much more angry and much more precautious how to feed your child. So that's why it's important that this post-pandemic crisis do orient all the economic to be smart and flexible and enable the most vulnerable groups to be part of it. Because the past has shown that any mainstream policies would always forget the most vulnerable groups. And there will be, again, it was mentioned before, the civic society organization across the countries to raise their voice again, and then again, and again.
Thank you. Does anyone else want to comment on this one, or we could proceed maybe with the last question?
I have one quick thing to say about it, which is that I really hope that online education is not the future of schooling. From an LGBTI point of view, many households and families are not accepting of their LGBTI children. And so the only escape that LGBTI children have from an abusive or violent home is school. And the increase in domestic violence and mental health issues experienced by LGBTI children that we're seeing now can't be mitigated by better online technology for education. It's really about getting space from your unaccepting family members. So I hope not.
Thank you. And actually, the last question comes to you again, Ciánan. So it says LGBTQI plus society are especially vulnerable to gender-based violence, especially during the pandemic. Are those events of violence reported by health professionals, or are they usually neglected during the pandemic?
So gender-based violence against and in-home violence against LGBTI people is radically underreported. The Frost study asked about this as well, and found that I'm just finding your answer really quickly, that 75% of incidents of violence experienced by LGBTI people weren't reported to anyone, not to an organization, not to a healthcare provider, and not to the police. We are working with our member organizations to try to come up with mechanisms for documenting this kind of issue, but when domestic violence, is particularly including sexual assault, happens against LGBTI people, the fear of reprisal from whomever one reports to is very, very high. And the thing that you can do, again, as healthcare providers, is make clear to your LGBTI patients and to ones that are not out to you, right? So it's really about having a consistent practice that you are a safe zone, be it having a sticker in your office or always making some kind of subtle remark that makes it clear that you're a space, having a flyer in the front room, wearing a button, whatever it is, that makes it so that people know that you would be accepting if they came out to you about being LGBTI. Sorry, and I prefer LGBTQI+, but ILGA Europe's acronym is LGBTI, so you keep hearing me say that, but that's not to try to sort of swerve away from the acronym you're using. Show that you are an accepting person that might be able to be supportive to them, and that's a better way to increase the likelihood of these incidents being reported, because they are dramatically underreported.
Thank you very much. If there are more questions, you can type them in, and maybe we could send them to our panelists and they could type the answers. If you will joined through the registration form, you will receive an email. So if there are further questions, please don't hesitate to either email them back to us or type them in right now. And I believe our panelists will be happy to answer them. If not, we can close for now. So I believe today's okay, thank you, Katerina. I will forward this to our speakers on a second time. So I believe after today's panel discussion, we all feel a little bit more shocked, educated, and at the same time, hopefully inspired to try to make some change, at least in our local medical faculties or in our hospitals, and to try to advocate more as well, to include more lessons probably that need to include vulnerable populations as well. So thank you so much to everyone that joined today. Thank you once again to our speakers who, despite their busy schedules, even though it's a pandemic, made the time for us. And thank you to everyone who attended. We hope to see you all soon, maybe in a better situation, and yeah, in a little less sadness. Have a good evening.
Yeah.
You too.
Thank you.
Thank you very
Thank
much.
you. Bye-bye.
Bye-bye.
Have a nice
you.
panel. Thank you.